Low back pain is defined as pain and discomfort localized below the costal margin and above the inferior gluteal folds, with or without leg pain. The lifetime prevalence of low back pain is reported as over 70% in industrialized countries. Peak prevalence occurs between ages 35 and 55. Recurrent and chronic pain account for 75 to 85 of total workers' absenteeism. The major limitation of MRI is that image acquired with patient in supine position, in a position of relative functional rest, but pain exacerbates in the upright position. And furthermore, MRI findings and clinical symptoms do not necessarily correlate in lumbar pain. We have negative findings in the presence of symptoms in a supine position. Here you can see the variation from upright position and supine position. We have a reduction of spondylolisthesis, a spinal variation with increasing breadth of the foramen and vertebral canal, and the widening of gap with the fluid on the facet at MRI. In the past, we performed weight-bearing flexion radiography, first tool for the evaluation of patients with lumbar spine instability, but the limit is it's impossible to study these structures. And then axial load MRI, but load is applied with caudocranial direction and not allow evaluation of the influence that is physiological represented by the weighted head, body, and muscle activation. Our purpose is we are evaluated differences between orthostatic and supine positions in facet joint fluid and spondylolisthesis at MRI. We performed a retrospective study. 63 consecutive patients underwent lumbar spine MRI for low pain. Each examination was performed in both standard supine and orthostatic position. We utilize a permanent magnet of 0.35 Tesla, tilting system that can rotate from 0 degrees to 90 degrees without the need for patient repositioning. The study was carried out at the table angle of 82 degrees in the upright position, becoming reproducing an orthostatic position. For a less patient stability problem, we perform upright position before supine position in order to avoid syncopal episodes. Here you can see the total time of the examination. For each level from L3 to S1, we evaluated the presence of a facet joint fluid and spondylolisthesis in the two positions. We consider absent, present, monolateral or bilateral, and spondylolisthesis was evaluated according to Meyerling classification and use McNemar T2 test for comparison. Here you can see the results for L3, L4, for L4, L5, and for L5, S1. The fluid in orthostatic position tends to reduce compared to supine position, whereas spondylolisthesis does not show significant change with position. We perform a biomechanical hypothesis. These discrepancies may be related to prevalence of late degenerative change in our patients with possible stabilization of lumbar spine. The process of degeneration which led to lumbar instability has been divided into three phases: temporary dysfunction, unstable phase, and restabilization by arthrosis. In conclusion, fluid in supine position tends to reduce compared to orthostatic position, where spondylolisthesis does not show significant changes with position. Further prospective study on younger patients should investigate the role of facet joint fluid and spondylolisthesis on lumbar pain pathogenesis. A multidisciplinary approach is necessary to establish whether and how those patients should be treated. Thank you.
Thank you, Dr. Ottonello. Is there any question from the floor?
Thank you for the presentation, Michael Bose in Copenhagen, Denmark. As I understood, you used the Meyerling classification for the anterolisthesis, is that correct?
Yeah.
That might be too crude, actually, measurement to see the change, because in
Yeah.
our experience, the change is happening within the skull. So the challenge here is actually to find a way to measure the change, which you visually see.
We don't measure the change.
That's
only change, no change, change monolateral, bilateral. No
Okay.
measurements.
okay.
Thank you. If there is no other question, we can... You have one? Yeah, of course.
Pick up first-degree spondylolisthesis, say, at L5-S1, which doesn't change from the supine to the upright position.
There's a change.
No, suppose, some of the cases you mentioned, you didn't say any change of the degree of spondylolisthesis.
The change is on the fluid, only on the fluid.
On the facet joint itself.
Yeah.
However, neurosurgeons or spine surgeons wants to know is there mechanical instability or not. The spondylolisthesis is exaggerated in flexion or not.
Yeah.
This is a very important issue.
Yeah.
That by a simple X-ray you can do it. This is one thing. The other thing, actually, a neurosurgeon or as a radiologist here, we don't do the examination while the patient in severe pain. In the standing position here with an open magnet, the examination is more than 25 minutes. This is too lengthy for a patient suffering.
Yeah, but it's important to identify younger patient in order to avoid a develop of a instability, chronic low pain.
I mean, actually, by a simple X-ray in the flexion and extension, you can answer this question.
It's possible, maybe.
Yes.
Thank you.
So in which patients would you suggest to perform upright MRI?
For younger patient, it's not a surgical problem. It's important to identify the younger patient that in the future may develop a chronic lumbar pain.
Okay, thank you.